Good morning. You guys hearing me all right? Well, it's really nice to be with you today. I see a lot of friendly faces and people that I've worked with over the years. Today's topic's about really healing the healers. And, sometimes in our rush to deal with medical innovation and help our patients and families, we sometimes forget that we too need care. Our colleagues need care, that we can't do our best work if we're distressed or suffering. And so as a good hospice and palliative care doctor, I've been trained to lean into things that are uncomfortable, lean into things that might be taboo, lean into areas that people might be running away from. And today we're going to lean right into that thing about burnout and clinician suffering. The real goal is that we find ways to support each other to experience the joy in this work, which we chose for good reason. And so this will be balanced with joy, but we're not going to back away from uncomfortable things. You heard about my bio. I don't have any conflicts of interest to disclose. We're not going to talk about off-label treatments. And although I have a lot of affiliations, my opinions I express today, these are my own. We're going to talk about the consequences and causes of clinician distress, including burnout, and rise of national initiatives to support clinician well-being. And I hope we'll get some chance for dialogue about what's going on here locally to support you. And then with stories and illustrations, I'm going to trace one physician's journey. I'll tell my story about moving from burnout to joy and how it helped me grow as a medical leader. And then we're going to explore what we can do to help each other thrive and to make our whole healthcare system a better place to work. So I'm going to tell you my story, and it's partly because one of the things I think is really important right now is that we acknowledge that there's been a culture of silence in medicine. It's supposed to be hard. You're supposed to suck it up. You're supposed to be tough. And I'm hoping if I tell my story, it will encourage others to tell their story and overcome this real culture of silence. So as we talk about clinician distress, whether we call it burnout or many other things we can call it, we talk about well-being or joy in our work, I'd like you to be thinking about multiple layers of how this affects us. How does it affect you? How does it affect people you work with, your team and your colleagues? How's it affecting your patients and your families and their experience? How about your family and your friends? Your organization, your team, the university? And how does this impact our whole healthcare system and society? You know, you can zoom out and we can talk about this on the level of the culture of our country and politics, or you can zoom in and you can think about how it affects you personally. But all these layers are in play when clinicians are in distress. So to lead off, we're going to talk about, this is an infographic from the National Academy of Medicine's Action Collaborative on Clinician Wellbeing and Resilience. And this is a project that started about 3 years ago. Organizations chipped in to participate in an action collaborative because there was a sense that something needs to be done and now about clinician distress. This was triggered especially by the recognition of an increased suicide rate in doctors and other clinicians. About 400 doctors a year commit suicide. Some of them are doctors in training. Some of them have committed suicide at work or, jumped off the roof of the hospital or were found in their call room. This has been a real wake-up call. And I don't know what's happened here in the Louisville community, but I know in many medical communities there has been an incident within the last few years where someone really beloved took their life. And this has raised a lot of awareness around the fact that the clinicians can suffer too. Also, you'll see in this graphic, just as a physician, you already have 2 times the risk of suicide of the general population. If you are an ICU nurse, there's a 1 in 4 chance that you would meet the diagnosis of having post-traumatic stress disorder symptoms. That's kind of interesting. A third of nurses report emotional exhaustion of primary care nurses. Physicians report rates of depression as high as 39%. These are really striking numbers. And the other thing that caught, I think, the attention of national policymakers, besides these suicides, is that the rates of clinician distress seem to have gone up dramatically, particularly in the last few years. So what are the consequences of clinician distress or clinician burnout? For the clinician themselves, an increased risk of depression, irritability, suicide. They're more distracted and more at risk for making medical errors that can result in patient harm. So it's actually a patient safety issue if clinicians are suffering. The clinician has an increased susceptibility to physical illness. There's an increased tendency to cope with alcohol and drugs. And the result can often be turnover, job loss, people leaving the field, people retiring early, people going to part-time as a way of coping. And of course, I don't know that there are any areas of medicine right now that aren't projecting workforce shortages. And so this becomes part of the workforce shortage issue too, if we're losing people to burnout. And then there's this point that, when you lose an experienced clinician, and you replace them with a new clinician, something's lost. We learn a lot after we get out of medical school and training. When I came into hospice, most of what I learned about hospice and palliative care I learned from nurses, and most of those nurses have been doing it for 10 or 15 years. When one of those nurses retires and a new nurse comes out of nursing school, very enthusiastic, raring to go, I think it takes them sometimes 2 or 3 or 4 years to get that kind of deep knowledge and wisdom, that more practical knowledge, that implicit knowledge that the experienced clinician has. So sometimes I think about what I learned from my African friend from Mali. He said in Mali, if an elder dies, they say a library burns. I think when an experienced clinician leaves the field, a library burns. We lose something when that happens. So our particular area of palliative medicine is not immune to this phenomenon, and reports have been as high as 60%. More reports are more around 30-35% of clinicians in palliative medicine test positive for the symptoms of burnout. And we held our own focus group at our annual assembly in 2014, and one of the participants said, this chronic burnout, it's like heart failure. It's chronic and it could kill you. And that's really an alarming thing to hear from a colleague. In this focus group, the docs reported that there were individual and interpersonal reasons for their distress, but also organizational reasons, issues around regulation, issues around paperwork, and other burdens that were adding to their displeasure in doing a job that they really otherwise would love. And a lot of folks were actually expressing concern about whether they'd be able to continue doing this work. And some were talking about leaving the field early. Now, I was saying that's in palliative medicine. In some other forms of medicine, like critical care, emergency medicine, particularly where there's a lot of high urgency life and death work, the rates can top 50% of evidence of burnout. So how would I know if I'm starting to have distress? There was a paper written way back in 2001 by Diane Meyer and others in JAMA where they really talked about the inner life of the physician. And sometimes our first clue that we're struggling with something would be, in symptoms or behaviors that could be red flags. One is when we find ourselves getting angry at the patient, angry at the family, angry at our colleagues. If we feel harassed or imposed on, if we're having intrusive thoughts about our patients, we can't forget them when we go home. If we have feelings of failure or self-blame or guilt, or on the opposite side, we feel like we're there to rescue everybody. We always have to be the hero, or we don't know how to cope with that. If we feel this personal obligation to save people, or we feel manipulated or victimized. And I can remember back in my own training that sometimes I was actually aware of this thought, literally this thought. I'd admit my 7th sick person of the night, and sometimes I'd say, I think I'm suffering more than they are. And that's a sign something's not right. All right? But maybe you can recognize that experience. Now, when we talk about clinician distress, this gets really complicated. There are a lot of causes, both external and internal. There are many different conceptual models. The terminology is, really inconsistent. We could spend a whole day arguing about whether something is burnout or something else. I'm not going to get into that, but the key thing is we're talking about when the clinician feels distress or the clinician suffers. What are the effects of that? What can we do about it? The language we use is really fraught also because, it's easy to fall into stigma, into reinforcing stigma or victim blaming. If a person's got an impossible workload and they're starting to show signs of distress and you come to them and say, you should just find some time to take a mindfulness course, that doesn't feel, blaming the victim. Maybe it's not their fault. Maybe nobody could do it. So we have to be careful that when we reach out and support each other that we don't get into victim blaming or reinforce stigma or reinforce this culture of silence. You have the exact same problem when you talk about the good. Are we talking about well-being? Are we talking about resilience? Or, do we even reach for something higher and talk about meaning, mission, joy? The words you choose really have an effect on people. And so here's an example of what will be a heck of a Scrabble board. And this is just some of the terms that I see in the literature when people are talking about clinician distress. And it's very interesting, by the way. If you read the medical literature, you'll see the term burnout used a lot. If you read the nursing literature, you'll almost never see the term burnout. You'll see terms like moral distress and compassion fatigue. And some of this has to do with whether I'm kind of putting the onus on the individual or I'm putting it on the external forces that are acting on the individual. But, depersonalization, loss of control, fears of malpractice, grief we don't get a chance to deal with, feelings that we're being asked to do things that are absurd, emotional exhaustion, fear of failure, compassion fatigue, trauma, post-traumatic stress kind of symptoms. All these things are in the differential diagnosis for a clinician who's in distress. And I don't want to oversimplify and say everything is burnout. But I do want to say, if you have a problem with any of these terms, let's just back away and say, do you have a stressful job? How many here feel like medicine is a stressful job? Most of the hands going up? For those of you who don't think it's a stressful job, good for you. God love you. I think it's a stressful job, particularly the way it's practiced today. And then the other question I'd ask is, do you ever feel distress working in this stressful job? And I think if you're honest with yourself, most of you say, yeah, sometimes there are days when it doesn't feel like it's worth it. So as we dive into this issue of how physicians can get in distress or other clinicians, by the way, this applies to nurses, pharmacists, it applies to all the members of the interdisciplinary team. We see it as well in dentists and veterinarians. I think there was an incredible NPR segment this weekend about veterinarians who also have twice the suicide rate of the general public. And in their case, they often are in private practices and work in very isolated situations and don't have that collegiality that we might have in medicine to support each other. So if we're going to talk about burnout for just one conceptual model, one set of terminology, the classic triad based on the work of Maslach is emotional exhaustion, depersonalization, you feel dehumanized or you tend to dehumanize the people you're around you, and a decreased sense of personal accomplishment or efficacy. You just don't feel like you can accomplish anything or what you do matters anymore. Another way of thinking about a recipe for experiencing distress or burnout or frustration is this little Venn diagram. There's a really big circle of things that I feel responsible for as a doctor. But I can't actually control all those things. For example, I can't make all my patients live forever, but I may feel a responsibility to try, right? There's also a lot of things I care about that I may not be responsible for, but they matter to me. And there's only a smaller amount of things I care about and things I have control that I can do anything with, right? And where the people who are most happy and well-adjusted put most of their time and energy where they have some control and they can do something about it. If you think about that old serenity prayer that's used in 12-step programs, it's actually based on this concept, right? Give me the serenity to accept the things I can't change. Those would be things I care about or feel responsible for, but I can't control. Let me accept those. Give me the courage to change the things I can. That's what's in the intersection where I do have some control. And the wisdom to know the difference, to know where these boundaries are. Because when we put a lot of emotional energy and worry into things we have no control over, it doesn't help us move forward. So one thing to think about if you're feeling distress is, am I feeling responsible for things I really can't control? Am I worrying about things I can't control? Are there ways I could focus more on where I do have an influence and can make a difference? Another way of looking at sources of suffering or distress in clinicians comes from the work of Joan Halifax, who's a Buddhist writer, a palliative care expert. She wrote an article called The Precious Necessity of Compassion. And in it, she pointed out that there were at least 5 layers of distress she sees in palliative care clinicians. There's the first layer, which is just job stress. I mean, our jobs are hard. The hours are long. We're asked to do a lot of things that are tough. But then there were these other layers. The second layer she called secondary trauma and grief. We come to love our patients, and when our patients die, we may feel grief. But if we don't have time or a mechanism or a process that allows us to grieve, if we just shove that aside and move on to the next patient, then we can get this cumulative burden of grief. And sometimes we witness things that are traumatic. So I told you 24% of ICU nurses have evidence of post-traumatic stress disorder because they're actually witnessing in their work things that are traumatic that lay people would easily be traumatized watching. And so that's another layer that doctors have that I guess, pipe fitters wouldn't have. Then there's this issue of moral distress. There's a lot of nursing literature around this, and that is when you have a strong conviction and belief about what's the right thing to do, but that's not what's happening, and you have to participate in something you feel is wrong. So this would include, for example, an ICU nurse who has a 95-year-old patient with many, many chronic illnesses who's on a ventilator and is not getting better, and they feel like that patient shouldn't be on a ventilator anymore because it's not really helping, and yet they have to take care of that ventilator. It's not in their control to stop that because the family's not there or the doctor hasn't written the order. That kind of moral distress, I'm participating in something that doesn't feel right, is something that we see in medicine that maybe a pipe fitter wouldn't have to deal with, even if they had long hours. Then she mentioned this thing called horizontal hostility, and that's this tendency that when we're under distress and we're working in a stressful system, we sometimes take it out on each other. Have you ever seen that? I don't know why this is the phrase, but for many years I've heard this phrase that comes out of the nursing education system, which is that nurses are accused of eating their young. And it's kind of a joke, but it's kind of not. Well, I think we do that too as physicians, or nurses and physicians get in a big tug of war. But a lot of times when we're stressed, what we end up doing is then taking it out on our colleagues and teammates and the folks we should be training and coaching and mentoring. And this just becomes another whole layer of distress that can happen in a system where people are under a lot of stress. And then this fifth one, which she called structural violence, is the baked-in stuff that's just unjust and unfair and absurd. If you have to send a homeless patient, out of the hospital and none of their social determinants of health are going to be addressed and they're going to be back in a week, no matter what you do, that feels very futile and why it's baked in to some of the inequities in our actual system. Make sense? So I'm telling you there's a differential diagnosis of distress. It could come from many of those places or all of those places or some combination of those places. But wherever it's coming from, It's not helping us take good care of patients to have that distress, or certainly to ignore that distress and just suck it up and not do anything about it. Okay. So the National Academy of Medicine launched this action collaborative I told you about, and I got to participate on one of the work groups that was the conceptual model work group. And here's what they came up with. Here's what we came up with. To me, it looks like a Pac-Man eating a blue dot. I don't think that's what they thought it was, but at any rate. I want to just tell you a little bit about how this is put together. At the very center is patient well-being. That's what we're all here for. We're all here to help patients and families have better lives, right? And that happens because there's a good relationship between the clinician and the patient. Much of the real good medicine that happens because of a relationship with the clinician. And the clinician brings to that relationship their own stuff, their well-being or not, their joy or not. And that interaction of the clinician and the patient, is at the center of this. And what we really believe is that we can't expect to have patients that are experiencing healing and well-being if the clinician is miserable. Because how could you keep that out of the equation? So that's what's at the center. And then what you see around the side, the 5 yellow ones are external factors, society and cultural factors. That's some of that structural stuff I was talking about. Rules and regs, organizational factors, the culture at the place you work. Learning practice, environment issues, and issues around training, resident work hours, all that kind of stuff. And then your own particular job description and healthcare responsibilities. All those external factors play a role. And then a few internal factors play a role, like personal factors, your own personality, are you a perfectionist, that kind of thing. And then your own skills and abilities, what you've learned to do to cope. And the point here is most of these things are external to the clinician. However, where that clinician may have the most control is the little section that's internal to them. So that's something to think about. I don't know how you can talk about anything that has to do with human attainment and not bring in Maslow's hierarchy of needs. I always show Maslow's pyramid, so call me a social worker. But this is important in what we're talking about. So Maslow said there's sort of this pyramid of needs. And they start from the most basic sort of survival needs, and they work their way up. And at the top of the pyramid, you're experiencing joy and meaning and transformation, and you're the best human being you could possibly be. But it's very hard to be at top of that pyramid if you're ignoring all those other needs, those basic safety needs. So it turns out the physiologic needs are the most basic. You have to eat, you have to drink, you have to sleep, you have to use the bathroom. And, people will take risks just to make that happen. The next thing that's most important is safety, pretty basic. Then you need to fit into some kind of a social structure. We can't live as an island. We can't live alone. Another layer that's even better is to not just belong to a social structure, but to be claimed and esteemed by that social structure, to actually feel like I belong here and people value me. And those are all the things upon which is built this fancy stuff of I can work on my personal mission, become the best person I can be, and experience joy and transformation as a person. All that stuff which can happen in medicine and make this the best profession in the world are in danger if our basic physiologic needs, our basic safety needs, our basic need for belonging aren't being met. So I don't know if you can buy this, but I will own up to the physiologic sometimes trumping everything else when I've been in busy medical circumstances. I can remember specifically at that Good Samaritan Hospital when I was an intern, I had the code beeper. I'd been up all night, probably had admitted 6 or 7 patients, slept maybe an hour, and it's noon, and I still have more rounds to do, and I go to the cafeteria and I get a cheeseburger and French fries and a chocolate milkshake. And this is going to be like my best 10 minutes of this 36 hours. And as soon as I sat down, the code beeper went off, and I had to go do a code. And when the code was over, I came back, and my tray was gone, and the place was closed. Now, here's what I'm going to tell you about the story. I don't remember who I coded, and I don't remember if they made it. All I remember is I didn't get to eat my cheeseburger. And it's funny, but it's also tragic, right? If we want people to be tuned into the folks they're caring from, they can't be worrying about whether they're going to get to go to the bathroom. So, I think this attention to people's basic physiologic needs is really not anything we should ignore. Sleep deprivation does not make you a better clinician. All right? I'm going to trust you guys with a bad old joke. Nurses will forgive me, I think, but the story is that the L.A. coroner, the Louisiana coroner, they bring in a body from the swamp, and the guy does the autopsy, and they say, "Were you able to identify the victim?" And he says, "I don't know who the victim is, but I do know this: they're a nurse." He says, "How do you know that?" Stomach was empty, bladder was full, rear end was half chewed off. Okay? Nurses sometimes don't get a break. Some of them work a 12-hour shift, and they have to get a buddy to cover to run to the bathroom. Okay. Getting pretty basic here, right? All right. So, you've all heard the triple aim, and that's really driving this value-based revolution. Let's look at population health. Let's deliver better value. That's better outcomes for populations. That's lower costs and better value to our spending, and that's a better experience for patients and families. But are any of those possible if in the course of trying to do that, we destroy the clinicians that are supposed to care for them? Doesn't all of this depend on clinicians that can do their best work? So some people have said we should call it a quadruple aim and say care of the patient requires also care of the clinician. Okay, so we're going to get into my telling you my story, not because I think my story is dramatically different from others, but because I guess I want to take one shot at sort of opening up the discussion and taking a shot at the culture of silence. So I'm a successful doctor, but I can tell you there have been times in my career when I was flat out, burned out. And I was able to make my way through them and experience even more joy in life. But I'm not going to ignore those times and what they were like. So for this Action Collaborative, they created an exhibit of art from people of all abilities, which meant I could contribute to it. And this is one of the things that they put in their exhibition. So I'm going to tell you my story in 300 words and 6 illustrations. It's grossly simplified. It covers many years of practice. But I want you to think about whether you resonate or you know someone who would resonate with any parts of this, okay? So first, becoming a doctor, I put my whole heart and mind into helping others. But I wasn't prepared for the physical and emotional exhaustion. Sleepless nights, responsibility for life and death, and witnessing suffering took a toll. It was easier not to see my patients or myself as human. Sometimes I wanted to scream. It hurt when my patients died. I tried to be perfect. When a patient sued me after an unpreventable complication, my trust was shattered. I feared losing my colleagues' respect. I was in exile. I tried to hide my suffering and pretended to be okay. My favorite mask was the workaholic. My own healing required accepting help from others. I leaned on my wife's unconditional love. I joined a physician support group, and I found that my peers had the same struggles. I got counseling and coaching, and I considered my options. Now, I listen to my heart and I reflect on my experiences through journaling, sketching, and talking with friends. I have a new mission: to humanize the healthcare experience for patients and clinicians. I found joy again in practicing hospice and palliative medicine, where teams tend to the body, mind, heart, and spirit. Nothing beats visiting patients at home, surrounded by what they love and living their own stories. I can be my best self, lean into worries, and celebrate the good in life. And today, as Chief Medical Officer for the American Academy of Hospice and Palliative Medicine, I'm grateful I can support others in this important work. And I encourage all healers to be well. It's not okay to suffer in silence. You are not alone. Help is here. So in my own story, if I read it and think about it, there are a lot of themes I hear when other people talk about their distress as clinicians, managing high demands and high stakes. Would you say that's true in your practice at times, that you're managing high demands and it's high stakes work? Do you witness suffering? Do you experience futility? Do you ever have that feeling that you could never do enough? Do you ever have that feeling that you're responsible for things you can't control? Do you ever bury your feelings of grief or your feelings of moral distress and just put your head down and go see the next patient? Hope it'll go away. Are you a workaholic? Are you a perfectionist? Do you suffer in silence? Do you feel isolated? Do you resent the time you have to waste on things that don't seem valuable to you anymore? Any of those things ring a bell? So what can we do? Systemic factors far outweigh personal factors in driving burnout and other kinds of clinician distress. But the fact is we have more control over changing our own response than we have control over fixing the system. And so there's a balance, and let's do what we can for ourselves and each other. And at the same time, let's try to make the system better. We have to think globally and think systemically, but sometimes we just have to act locally. Make sense? Maybe we just have to be the change we want to see. If I would like the healthcare system to be more humane, maybe I need to start by acting more kind. So as we're thinking about how to deal with distress, there are a lot of national resources. This, like I say, it's a big issue for the National Academy of Medicine. They actually have commissioned a white paper study on the best practices to address systemic issues that drive clinician distress. There are all kinds of resources on that website. The AMA has something called Joy in Medicine, which focuses more on workflow issues, how you can establish a workflow that allows you to spend most of your time doing your best work. The Schwartz Center for Compassionate Healthcare has a lot of resources about building teams and increasing our compassionate care of patients. And if you use burnout as a search term on this website for any JM Catalyst leadership, you'll find all kinds of leadership articles about what leaders can be doing to address this. So in that National Academy of Medicine work, you'll find two very recently reported case studies that talk about what a couple of systems have done about this. One of them is at the Ohio State. And this particular model of systemic change is really sort of started at the top. They made it a strategic goal for the entire Ohio State health system, including nursing school, medical school, residency training programs, hospitals, outpatient clinics, that the entire system made clinician wellness a priority. And then what they did is hired a chief wellness officer and put them in the C-suite. And they created wellness councils that had leaders from all the different activities engaged. And they did this system-wide. They instituted something called Schwartz Rounds. I mentioned that Schwartz group for compassionate healthcare. Any of you ever attended a Schwartz Round? Do you know what that is? Okay. Have any of you ever attended a mortality and morbidity conference? It's the opposite of that. Okay? So an M&M conference is something bad happened. Who's responsible for, who didn't check the potassium? No, Schwartz rounds are, something happens, there's a patient experience, there's an outcome, and the team gets together. It's a multidisciplinary effort, and they really think about what was the experience that the patient and family had, and what could we have done to make this a better experience or to support each other better as we do this kind of difficult work. So it's the same kind of process where people get together to look at a case and learn from it, but the motive behind it is so all of us can provide better care and not to do any kind of finger pointing or blaming. The Ohio State then put in all kinds of resources for counseling. They created peer support groups. They have mentoring and coaching. And they've trained people in trauma recovery, mindfulness, and wellfulness. And in fact, they put together these little teams that are sort of rapid response teams that if something happens, the gunshot wounds come into the ED and it's traumatic and they die, then they had actually a team that would go and spend a couple minutes with the clinicians to just give them a chance to have a pause and get a little support. And these kinds of things were pretty powerful. The impact at Ohio State is they believe that they've improved their productivity to the tune of $15 million. They calculate a return on investment of $3.65 for every dollar invested in wellness programs. So my MBA says that sounds good. They have decreased anxiety, depression, stress, and suicidal intent being reported by students, faculty, and staff in multiple clinical settings. They've increased their academic performance, and they've increased the levels of healthy lifestyle behaviors. So there's a system where the leaders at the very top said, we're going to do something about this. We're going to change the culture here. We're going to provide resources, and they believe it's working. Another example is the Virginia Mason, where they had a particular medical center where they focus on workflow optimization. They actually use like the Toyota plant model for rapid quality improvement. And they created a whole new workflow, and this has had great benefits. They use medical assistants to the very top of their ability. Everybody practices at the top of their license. They studied and found out that the typical resident visit is 20 minutes, and so they changed their scheduling to schedule visits in 20-minute increments, not 15-minute increments. And for every 3 to 5 20-minute visits, you're forced to schedule a 20-minute non-visit. There's a 20-minute pause built in for every 4 or so patients you see to catch up, to make phone calls, to have a wellness break, to do whatever you need to do. And through this kind of attention, they've actually come up with a system where people get home 1 hour after they see the last patient. What a difference in people's lives. And they find that they have very high levels of clinician contentment and engagement. And in particular, the employees actually believe these things are helping them have more joy or less distress in work. So I mentioned that a lot of this is really externally driven, but when it comes to what we have control over, what we can do something about today, sometimes we have to think about ourselves. How can we manage our wounds and the folks around us? And I'm going to suggest this starts with adopting an attitude of kindness toward yourself, toward your team, toward everyone. Henry James said 3 things in human life are important. The first is to be kind, the second is to be kind, and the third is to be kind. Little kindness can go a long way. How can we show kindness? Expressing gratitude. How often do you actually thank the people around you? What does it mean to you when somebody thanks you? Do we connect to meaning whenever we can? Do we actually show that every person matters, including the janitor? Do we show empathy and curiosity? Do we take care of people's basic human needs? Do I give people breaks during my staff meetings so they can use a bathroom? Do we seek to understand the distress that we might see in our colleagues? So I'm going to tell you a really quick story here. In my own very condensed version I gave you of working through burnout. There was a time when I was a primary care doc working at a small community hospital, and I was running on empty. I was probably getting 4 hours of sleep a night. I was on call every other night. It was brutal. Where I was doing my morning rounds, and I'd ordered an x-ray on a patient, and it hadn't been done for some stupid reason. And I threw a fit. I threw a fit at the nurse's station where visitors could see me and the nurses could see me. I might have slammed my hand down on the table. I might have thrown a chart. I raised my voice. I think I cursed. What is that? That's called disruptive behavior, right? That is not okay, right? And what happened is a nurse who knew me and cared about me grabbed me, took me into an empty patient room, sat me down, said, "Stop, breathe." And then she said, "I am worried about you. I've worked with you for years. You're one of the good guys. This isn't you. What's going on?" And that really was a wake-up call to me to get help. That's when I joined the physician support group. That's when I got some counseling. That's when I started thinking about, do I actually want to do this job, or is there something else that would be better for me? And the point I'm making is she had another option. Her other option could have been disruptive doctor, call security, call chief of medicine, suspend him, and begin the disciplinary procedures. Now, I'm not saying it's okay to be disruptive. What I'm saying is that little bit of kindness from a colleague made all the difference for me and allowed me to stop acting that way and really take responsibility for how miserable I was. Does that make sense? Can we do that for others? When you see somebody in trouble, can you just offer them a cup of coffee? What can we do together to create safe and inclusive spaces? So I've heard some people say that you hear a lot of opinions about why we're more burned out now than we used to be. The electronic health record ranks really high on the list of people that get blamed. But you know what else I've heard? We don't have a physician lounge anymore. Have you heard that one? That safe place where I could come and there's just other doctors and I can complain about a patient who's driving me crazy and I'm not going to get written up and then I go on, we support each other. Can we forge connections to our peers in mission? And can we advocate for systemic changes, participate in innovative quality improvement and performance improvement programs? Can we work more in teams? Can we take responsibility for our own self-care, learn some mindfulness, set good boundaries? So, you don't need to hear from me what makes for good self-care. A lot of it's just basic physiologic stuff. Get enough sleep. Eat healthy, exercise. Don't use too much alcohol. Don't cope that way. But also, from a spiritual and emotional standpoint, self-care includes just building little tiny pauses in your day where you stop and remember why you're doing this. So we've seen some programs have reported a real decrease in grief and secondary, sort of trauma and post-traumatic stress symptoms in their, say, critical care teams just by doing this pause. When a patient dies, they just all stop for a few minutes and acknowledge what's happened. That little pause, it didn't have to be much, it was just a couple minutes, but rather than running into the next room and acting like nothing just happened, has made a difference in people's ability to cope. A little pause can make a big difference. Look for things to be grateful for. Get out into nature, whatever it takes, even if that means, watching a pigeon in the gutter. Which it might be what it is if you're working downtown. I don't know. Know what meaning is for you. And again, when I talk to people who are really good at this, they really are well adapted, they're joyful, they're resilient. It's not because their job isn't stressful. It's because they know why they're doing it. And they'll have rituals that they do at the beginning or the end of their day. Like they come in and when they put on the white coat, they'll say a little prayer or there's something they say that reminds them why they're there. And at the end of the day, they take off the white coat and they say this little thing and they're not a doctor now. They're not a doctor until the next time they put the white coat on. This is, you can build it into your passwords. You can just take a concept that really gets at what mission is to you and, put a few punctuation marks and numbers and stuff in it so nobody can guess it. And every day that you're logging in, you're reminding yourself, why am I here? So when I worked with a coach to work through my own burnout, she encouraged me to have my own mantra that gets at what I'm trying to do or what matters to me. And this is what we came up with. By the way, my spirit guide is a moose. Can't explain why. I practiced for years in New Hampshire, and there's something about the moose. So I am a commitment to trust and a source of love. I'm committing to trust, even though that's hard. I want to be a source of love. I'm a commitment to forgive. I'm a source of healing. I'm a commitment to play. I'm a source of joy. For me, if I'm not having any fun, if I'm not playing, if I can't bring creativity into my day-to-day work, that's the first sign something's wrong. So, we have, about 10 minutes left, am I right? And I don't know if it's possible to bring the lights a little bit back up. And I thought this might be a nice time to get some dialogue going about, is there anything in this talk that you resonate with or react to? You don't have to agree with me. But also I want to be thinking about, what are we doing here on a personal level or on the level of our team or as an organization? What are we doing here to address the distress that clinicians experience when they do this stressful work so they can do their best work and find joy again? So let me open this up. Yes, sir. Good to see you.
Engaging, refreshing, and important talk. So I have two comments. The first is a little sad, but it might help someone. The second one's a good comment. A guy in my medical school class, won't give his name, we'll call him Richard Ford. For those who like poetry. Wonderful guy, nicest guy in the world here at medical school, got good grades, married, polite, had kids, perfect guy. Went down to a little town in Kentucky, got over-engaged, everybody loved him, he was great. Success sometimes can be a bad thing. Started going in a little earlier, started staying a little later. Going in a little earlier, stay a little later. On vacation, had his phone with him, had to call. And then we found out, this is probably 10, 15 years ago, he put a bullet in his head. So, hopefully nobody in this room is in that, but if you are or you see somebody that is, if you see that cycle going, I wish if I'd have been closer to him, I wish somebody could have done something. And it's a true risk. Now, so that's the sad but learning story. Now, on the positive side, and you and I have worked together, there were twice in my long career that I had a lot of what you're talking about. And in fact, I used to tell people, I'm going to stay in this job that I have now until I turn 50 or get admitted or leave. They would laugh, but it was honest to God's truth, because what you do is you balance what you need, your salary, what you need for your family, versus your personal health and well-being. And I just barely made it to 50 in the practice. And then I gave it up and tried something different. And it was so refreshing. It's a hard decision. Whenever you make these decisions, usually for these young people, usually you will trade dollars for peace and happiness and health. So I've done that twice in my career, thought something was going to work, and it worked for a long time. But both times that I made a switch, it was worth every penny of it. So I just passed that on.
Oh, I really appreciate your sharing both parts of that story. And that's my own story, too, is that the 2 or 3 times in my life, like at the end of my original medical training, when I burned out of primary care, and then 5 years ago when I kind of got tired of doing straight administrative work at the hospice I was working for. In each of those cases, the distress was actually a catalyst for me making a personal change that made my life better. But I couldn't have done that if I didn't recognize I needed to, and if I didn't have the support of people to do it. So I appreciate your sharing that. I will also share that in my case, I've never had suicidal thoughts, even though I've been pretty darn burned out at times in my life. But I did have other unhealthy things like fantasies of how I would escape. And one was that I would often think about, what if I just went blind? Wouldn't that be lovely? Because if I went blind, nobody would expect me to be a doctor anymore. I could quit medicine with no shame and no obligation and take sax lessons and sit on a bridge and play jazz saxophone or something. And that's pretty sad when you're wishing yourself blind so that you can have an out, because you don't know any other way to get out. Yes, please.
There's something magic about empathy, and I like when you started to talk about making it about the patient and the patient satisfaction. And so for those here, the Kentucky One system has 13 hospitals, and a couple of years ago, they did a satisfaction survey of the staff, and they compared it to the satisfaction of the patients. And in every single hospital, they were within a few points of each other. So in other words, if your patient sat scores were 50%, your staff satisfaction scores were 50%. And what that means is that here, if our scores are 30%, which they are, then the staff satisfaction is 30%. So you mentioned mood is the infectious disease here, and your patients will do better if you're happy. So you almost have to bring it on and be happy to your patient, and then they will smile back, follow your medication recommendations more likely, less likely to sue you, more likely to be compliant. So talk a little bit about that, because I think that's where we pull it to get us all up, both the patient and the physician.
Right. So this was a big conversation at the National Academy of Medicine's Action Collaborative, too, as I said, here, this is organized medicine. We're going to take on the issue of burnout, and we're going to need to bring the public with us. And on the one hand, they said if we lead with doctors are burned out and that's harming patients, then we might cause a mass panic or get, undermine the fragile trust that people already have in us. And yet, we can't just say it's about doctors need to feel better. It really is about if we're the best people, the happiest, the healthiest, the most well people we can be, we provide the best care. And we bring to that patient-care relationship the care and attention they need, the compassion they need. Yes, there are lower lawsuits. We're less likely to make a mistake. We're less likely to overlook a clue in the patient's story or history that would cause us to do the right thing. So even if you subscribe to the old idea, which has got some harm in it, that we're supposed to sacrifice ourselves totally to, I don't feel like I'm that old. I'm 61. I trained in the mid-'80s, but I definitely heard my mentors say, don't even think about getting married or having kids. Medicine is a jealous mistress, and you're giving yourself to medicine. Well, okay, maybe we don't need to do that anymore. But even if you still believed in that, I could come to you and say, but do you want to take good care of your patients? Because you may not be aware of it, but if you're walking around wounded, it's affecting your patients. It's affecting your colleagues. It's affecting your family. If you don't want to take care of yourself for your own sake, take care of yourself for everybody else's sake. I'm a nice guy. I threw a fit at the nurse's station. That was not okay. All right? So, yes.
It's helpful. In our organization, ULP is our organization, part of it, and one of our clinics was in distress, and 3 people left, and everybody was quitting, and it was a big thing. And ULP said, your clinic is understaffed, and now they are staffing our clinic up to full staffing. So you need your team. You need your MAs. You need your
team.
Test. You need social workers. You need the nurse practitioners. Same thing happened in the hospital. We call it Cook's Last Stand, or whatever you call it. But internal medicine physicians could not take any more patients. We were totally burned out. And the hospital stood up and gave us nurse practitioners. And so I think you hate to get to this crisis, but you have to get to a crisis, and then people do help you. We have gotten help.
So it's fun to hear about Cook's Last Stand. And I would say that, you need if you're on that Maslow's pyramid of need, we need basically enough people to actually just get the job done, right? But if you want to get further, you don't want to be at 30%, you want to be at 99%, patients are engaged and happy with the care they're getting from you, then the team alone isn't enough. Then the team has to also develop a culture and practices that bring out the best in each other. And this is where if I leave you with it, I hope you'll go away from here thinking about, first of all, if you're in distress, that you'll talk to somebody about it. But secondly, that you'll think about what's something I can do within the sphere of influence that I have, big or small. What's something I can start doing daily to transform this? And it might be as simple as pausing and thanking somebody once a day. You'd be surprised the difference that can make. And I think with that, we'll need to wrap.